Okay, so we're just going to give everyone like one more minute as people are signing on, and then we'll get started with the webinar. Hi, everyone. Welcome to the webinar, All in the Family, Hereditary Risk for Gynecologic Cancer. I'm Maggie Nicholas-Alexander, the Ovarian Cancer Program Director at SHARE, and I'm here with Nefertiri Moore, the Outreach and Uterine Program Coordinator. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 45 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org.
We would like to thank FORCE for partnering with us on this webinar. FORCE's mission is to improve the lives of individuals and families facing hereditary cancer. To learn more, visit their website at facingourrisk.org. All participants will be muted during the presentation. When Dr. Frey finishes presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. The chat section will be disabled when asking questions. Remember that the presentation is unable to give specific, the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon.
And now I'd like to introduce our speaker today. Dr. Melissa Frey is an assistant professor of obstetrics and gynecology in the Division of Gynecologic Oncology at Weill Cornell Medicine. Dr. Frey specializes in all aspects of gynecologic oncology, including surgical management and chemotherapy for cancers of the uterus, ovary, cervix, vulva, and vagina. Dr. Frey's research focuses on genetics and genomics in gynecologic cancer. Much of her research has focused on genetic syndromes that predispose to gynecologic cancer, including hereditary breast and ovarian cancer, BRCA1 and BRCA2, and Lynch syndrome. Thank you so much for being here today, Dr. Frey. I'll turn it over to you now.
Hi, great, thank you. Can you see my slides and hear me?
Yes.
Great, thank you so much for the opportunity to be here and to speak about this really important topic tonight. So I'm just going to start with some basic definitions that I think will help us as we talk about some of these genetic syndromes. So first, cells. Cells are the building blocks of our body. They make up all of our organs and tissues. And every cell contains DNA. And this is the hereditary material and really the code for building and maintaining cells. Big sections or strips of DNA are called genes. And genes are sort of housed in chromosomes, and everyone has sort of 2 pairs of chromosomes, so 23 chromosomes pairs, one from their mother and one from their father. So this would be sort of like a strand of DNA, and then a gene is this long strand of DNA, and then this is packed tightly into chromosomes, which are found in our cells. So, why is that important? What does this have to do with cancer? What does this have to do with families? Let's just think about how, in general, are genes passed in families. So here's a woman. She has 23 pairs of chromosomes. She has a mother and a father, and she likely, or we know she got one set of chromosomes from her mother and one set from her father. So it looks like here, for this particular chromosome, she inherited the blue from her father, but there was a 50-50 chance that she would get either the blue or the gray. And then from her mother, she got the green chromosome. And then if she has a partner and goes on to have children, each of her children is going to inherit a mixture of her chromosomes and her partner's chromosomes. And now if we think about something like a BRCA mutation, so if this woman's mother had a BRCA mutation, there's a 50-50 chance that she would pass this on to her daughter. And then if her daughter developed the mutation or had the mutation, there's a 50-50 chance for each of her children that they would also then be passed on this specific chromosome that had the BRCA mutation. And this can be shared between men or women and goes sort of down through generations like this. And so sort of what's important to consider here is that it can be passed by either the mother or the father's side of a family. And unfortunately, a person just needs one copy of this non-functioning gene, a gene like BRCA, or we'll talk about Lynch syndrome, in order to get the cancer risk. So this is sort of the backdrop of how heredity works. So let's move right into BRCA 1 and 2. So what are the risks for a woman who has a BRCA 1 or 2 mutation? So we know there's a risk of breast cancer. Women have a greater than 60% absolute lifetime risk of breast cancer. There's also a high risk of ovarian cancer. We know for BRCA1 mutations, that's about a 40 to 60% lifetime risk, and a little bit lower for BRCA mutations, about 15 to 30%. So lower, but still much higher than the general population. We're learning more about the association with pancreatic cancer. This seems to be especially high in individuals with a BRCA2 mutation, where the risk of pancreatic cancer can range from 5 to 10%. And there's also likely an association with melanoma. That's also something that we're learning more about. And then for men, there's likely an association with prostate cancer. So for a woman with ovarian cancer, what do we learn by finding a BRCA mutation? How is this useful for a woman who's kind of dealing with a diagnosis of ovarian cancer? Well, I think, especially of late, is the treatment implications. We now know there's a class of drug called PARP inhibitors, which I'm sure many of you in the audience may have heard about, which can be used for many, many women, but seem to be especially effective for women who have a BRCA mutation. It also can inform a woman about her risk of other cancers. So it's important to know that it's not just ovarian cancer, but also a woman may be at risk for breast cancer, melanoma, pancreatic cancer. And we also know, and we'll get into this, that there are things that women can do to prevent or detect early some of these cancers. And then finally, the risk for family members. If we think back to that family tree we just looked at, we know that for all first-degree relatives, there's a 50-50 chance that they also share this mutation. And so it can be really critical to share that information with family members. So what are the options for BRCA 1 and 2 cancer risk reduction? So if let's say we find a woman who's never had a cancer and she has a BRCA 1 or 2 mutation, what can we do to prevent cancer? How is this information powerful for her? Well, for breast cancer, there are guidelines, and the recommendations are for imaging. We'll kind of go through that. So starting at age 25, for a woman with a BRCA 1 or 2 mutation, there's a recommendation for a clinical breast exam. So a breast exam done by a physician every 6 to 12 months. Then starting at age 25, we actually do breast MRIs every 12 months. And then starting at age 30, we add, in addition to the breast MRI, we're also recommending a mammogram. And the way that works then is that a woman ends up getting imaging every 6 months. So it's kind of MRI, then a mammogram, then an MRI, then a mammogram. There's also the option for a risk-reducing surgery. So that would be risk-reducing removal of the breasts or mastectomy to prevent a breast cancer. And then also some women elect to take tamoxifen, which actually can prevent a breast cancer. So we've gone over the options for breast cancer risk reduction. What about ovarian cancer? Ovarian cancer is more complicated because we don't have any really effective screening, unfortunately. So really the hallmark of our recommendation is to consider taking out the tubes and ovaries. And we usually say between age 35 and 40. But the best guidelines that we have also state that for a woman with a BRCA2 mutation, it's acceptable to wait until age 40 to 45. And that's because it seems from the data we have that ovarian cancers tend to be younger in women with BRCA1 and a little bit older in women with BRCA2. But before making this decision, it's important to also look at someone's family history, their desire for fertility, because it really has to be individualized for the patient. For women who have not had their tubes and ovaries removed, we can consider doing ultrasounds, or also called sonograms, and a blood test called a CA-125. But it's really important to note that we have no great evidence, or really no evidence at all, that this is helpful. But it's sort of maybe better than nothing. But it shouldn't give us a false reassurance, because we don't really have any proof that this works. And then we recommend also for women, we can consider oral contraceptive pills. We know that taking oral contraceptive pills can significantly reduce the risk of ovarian cancer. There's the option for hysterectomy. There's some data that perhaps women with BRCA1 may have a higher risk of a uterine cancer called a uterine serous cancer. And so some women now are considering taking out the uterus along with the tubes and ovaries. And then, some of you may have heard, so there's some exciting work going on in whether or not we really have to take out the tube and ovary to prevent ovarian cancer, or if we can take out just the tube. And just to kind of quickly go over the anatomy, so you have the ovaries, and that's really what makes hormones. That's what makes follicles and oocytes, which are needed for fertility. And then there's the fallopian tube, and really the main role of the fallopian tube is just to allow fertilized eggs to travel from the ovary and into the uterus. We actually know that, and so the general recommended surgery is called a salpingo ovarectomy, and the salpinges are the tubes, the O's are the ovaries, so we recommend taking out the tubes and ovaries. That's the standard method of sort of cancer risk reduction. But it causes surgical menopause. And so for a woman who's 35 or 40, that's 10 to 15 years before she would have gone through menopause. That's the end of fertility. And there are many medical and lifestyle implications of early surgical menopause that, if we could avoid, would be wonderful. So we have some hint that the majority of cancers in women with BRCA mutations actually don't start in the ovary. So even though we're calling them ovarian cancer, that's actually a misnomer. It's actually a fallopian tube, and it seems that the majority are actually starting in this sort of end portion of the fallopian tube that rests right on the ovary. And that's important, because if we knew that were absolutely the case, then we don't have to take out the ovaries. If we just took out the fallopian tubes, we should be able to offer women the same level of cancer risk reduction. And so, the issue is that this is not standard of care, and we haven't yet shown that this is safe oncologically. There are ongoing clinical trials, and I think everyone is really, really hoping that we have positive results, because this would be a tremendous benefit to women to have that, again, that opportunity for cancer risk reduction without surgical menopause. But this is still an area that's under clinical investigation and really shouldn't be done unless someone's in a clinical trial. So those are the options for breast and ovarian cancer risk reduction. What about pancreatic cancer? In the past, I think, people have thought that pancreatic cancer is a very aggressive disease and there's not much in the way of screening or treatment, but this is also something that's changed over the last couple of years. And now we do have systems at our institution. We have a protocol for women and men who are at higher risk of pancreatic cancer, where there's imaging we can do. That's MRI, or that can be an ultrasound done at the time of an endoscopy or colonoscopy. And then for melanoma, we generally recommend that men and women see a dermatologist and an ophthalmologist once a year for a thorough skin and eye check. So we'll switch gears now and talk a little bit about Lynch syndrome. So Lynch syndrome is currently known to be caused by a mutation in one of these 5 genes. And I'm just going to kind of go through a long list of cancers. And, I don't think it's, important to know all the cancers, but just to know that there are many, many cancers that can show up in a Lynch family. And there's also, you'll notice that the rates of the cancers can vary widely. And that's because depending on which one of these mutations a woman has, the disease can look very different. So we know there's an increased risk of colon cancer. There's an increased risk of endometrial cancer. There's an increased risk of ovarian cancer, an increased risk of breast cancer, stomach cancer, pancreatic cancer, prostate cancer, bladder cancer, biliary tract cancer, kidney cancer, and brain cancer. So for a woman with ovarian cancer, what do we learn by finding a Lynch syndrome mutation? Well, similar for women with BRCA mutations, there are treatment implications. So we know that immunotherapy works very well for women with Lynch syndrome. And so that's something that can become available to a woman who has a recurrent or metastatic Lynch syndrome associated cancer. There's also risk of other cancers. We looked through that whole list, but we know, colon cancer, uterine cancer, and many others. And so if we know that a woman has Lynch syndrome, we also have to think about preventing or early detection for these other cancers. And then finally, again, the risk for other family members, because we know the risk is 50% for first-degree relatives. So what are the options for Lynch syndrome cancer risk reduction? Well, for uterine cancer and ovarian cancer, we offer ultrasounds, endometrial biopsies, and then risk-reducing surgery. So that's removal of the uterus and both tubes and ovaries. For gastrointestinal cancers, that's screening with colonoscopy and endoscopy. For pancreatic cancer, that's imaging again with MRIs and ultrasounds, and then dermatologic exams for skin cancers. So I kind of have told you a little bit about BRCA and Lynch syndrome, but kind of just let's think about this so in the context of an ovarian or breast cancer. So if we think about ovarian cancer, we know that about a quarter of the cases are due to mutations that are passed in families. So that's a lot, but it also means that the majority, or 75%, are not due to mutations. But it also means that if a woman has a diagnosis of ovarian cancer, then she has a 25% chance that if we do genetic testing, we will find something, and that's pretty high. And what genes cause ovarian cancer? So we talked about BRCA1 and 2, we talked about the Lynch syndrome genes, but as we're doing more genetic testing and as our ability to genetic test is now spanning more genes, we're actually finding there's some other genes. So there are some genes that seem to be related to BRCA1 and 2 called RAD51C and D and BRIC1, and those seem to also have an increased risk of ovarian cancer. And then there are some uncertain risk genes like PALB2 and ATM. And I think that over the next couple of years, we're going to further add to this list and understand more about these genes, just again, because more people are getting tested and we're learning more about the underlying genetics of these diseases. Breast cancer, we think probably about 10% are caused by genetics, and about 90% are not caused by genetics. And what genes cause breast cancer? Again, BRCA1 and 2. But then there's a whole list of other genes, and this list, seems to continue to grow, that do increase a woman's risk of breast cancer. And then we also have some uncertain risk genes and genes that we have to learn more about, which also may likely increase the risk of breast cancer. So again, let's go back to a woman with a new diagnosis of ovarian cancer. What are the implications of genetic testing? Well, if we find a BRCA mutation, that can be helpful in sort of understanding why did this happen? Why did I get ovarian cancer? What are the risks for other cancers? What treatment would be best? Should I use a PARP inhibitor? But then there's one more implication that I think we often overlook, and I've alluded to it earlier in the talk, and that's cascade testing. What is cascade testing? Well, I'll start just by defining cascade. It's a process where something, typically information or knowledge, is passed on. And for cascade testing, that means passing on that information of a mutation to relatives, because relatives also have the risk for the mutation and also have the risk for the cancers that are caused by that mutation. And so if we can allow people to have the diagnosis of this gene, we can also then give people the opportunity to do cancer prevention. So what's sort of the ideal use of genetic testing? If we could do this perfectly, if a woman were diagnosed with ovarian cancer, she would immediately get genetic testing. And if we found a mutation, that would then affect the way that we treat her. It would allow us to give her sort of the perfect targeted therapy. It would allow us to prevent or have early detection of any other cancers that she's at risk for. But then simultaneously, she would reach out to her relatives and they would be offered testing. And the relatives who had a mutation would then have the opportunity for cancer prevention. So things like risk-reducing surgery or MRI screening or things like that. But the problem is we know that less than 30% of relatives actually end up getting tested. And why is that? Why is it that so few relatives get tested? Well, I think that, I've thought a lot about this, and I think that's really on us as the medical community. And I think the issue is that a woman is diagnosed with ovarian cancer, then gets genetic testing often at the same time and finds out that she has a mutation. And we tell her that these are the things sort of she has to do. She has to cope with her cancer diagnosis. She has to often prepare or recover from a surgery. She has to prepare for chemotherapy. She has to navigate time off work, think about financial toxicity of cancer and cancer treatment and missed work, consider risk for other cancers. And while doing all of this, we, the medical team, say it is on you to reach out to their family. So I want you to think about all of your relatives. I want you to call them and tell them about your cancer diagnosis and your genetic mutation. I want you to explain sort of the complexity of the genetics and how these diseases are passed on. And then I want you to help your relatives get tested, because these relatives are often, going to want to ask you. You're the person who's giving them this information. And they're going to ask you, how do I get tested? So I think it's no surprise that it's a very, very flawed system. And I think it really should not be the burden of a woman with ovarian cancer to help her relatives get tested. And so some of the work we're doing in my group is thinking about how can we take this burden off of women with ovarian cancer or women with a new breast cancer and take it on as the medical team, who maybe is better equipped to deal with some of this navigation. And so one of the things we're looking at is clinician-facilitated cascade testing. And so that if a woman tests positive for BRCA1, all she would have to do is give us a list of her first-degree relatives and give us permission to contact them. And we could call them, we could offer them genetic counseling by telephone, and then we could even do their genetic testing by the mail. We can mail a saliva kit and it can be done by mail. And really the goal is to transfer this burden away from a newly diagnosed patient, put it onto the clinical team, and make this easy for relatives. This should be something that a relative can do in the comfort of their own home. And just to show you an example of what this looks like, this was a woman, a 36-year-old with an advanced ovarian cancer who found out she had a BRCA1 mutation. And she has all these relatives, and sort of they came to us and said, of course, right now we're prioritizing our sister's treatment, but we also, is there something we should be doing now that we know she has a BRCA mutation? And so we offered them participation in a study we had on, and within a month, we were able to test 6 relatives, and we found that 4 of her relatives had the mutation. And within 6 months, we were able to plug all of these relatives in for risk-reducing interventions and screening and being seen by doctors. And so I'm hopeful that that's the way genetic testing and cascade testing is going to go, because I think that's really one of the greatest powers of genetics. Why is it critical that we identify women with BRCA mutations and Lynch syndrome? So what are the population-based implications? So hopefully I've kind of shown you tonight why it's important for an individual woman or an individual family. But what if we think about the whole population, or at least the population in this country? So let's think about a disease like breast cancer. There are almost 300,000 new cases each year, and unfortunately over 40,000 deaths due to breast cancer. And if we assume about 10% are genetic, caused by something like BRCA1 or 2, that's almost 30,000 cases that could either have been caught earlier at an earlier stage or prevented altogether if the woman had known she was at risk. Ovarian cancer is much less common. There are only about 20,000 cases a year, but many, many deaths, unfortunately, among those 20,000 cases. And so if we assume that about 20% of women with ovarian cancer have a mutation, that's about 4,000 deaths each year. So that's about 4,000 cases of ovarian cancer that we could prevent if we knew in advance and gave the woman the option for risk-reducing surgery. And then finally, uterine cancer, very common, over 60,000 cases a year. It's the number that are genetically driven are lower. It's only about 3%, and the majority of that is Lynch syndrome. But those, again, are cancers, over 1,000, almost 2,000 cancers that could be prevented annually if we knew this information. And so what does that translate? That's about 34,000 cases of cancer each year that could have either earlier detection or prevention of cancer had we really harnessed the full power of genetics and giving men and women the option for genetic testing. So kind of one of my last topics, and then we'll open it up for question and answer. And this is something I get a lot from patients is, I've had genetic testing in the past, I think, should it be repeated or is once enough? So the first question I would ask is, what type of genetic testing did you have? And so we'll just go through what the possibilities are. So there's single site. And what that means is someone's relative has a BRCA mutation. We found that mutation, and we want to test for just that one mutation. So we could say yes or no, you have the same mutation as your sister. The Ashkenazi Jewish 3-site is a very commonly used test, and that's where we're looking for the 3 Ashkenazi Jewish founder mutations, or these 3 very common mutations that are found in Ashkenazi Jewish men and women in both the BRCA1 and 2 genes. And this is often what people of Ashkenazi Jewish descent have had, and it's often what insurance mandates we start with in this population. Then there's what's called single gene testing, and that's where we look at the whole gene. So for an example, someone may have had all of BRCA1 or all of BRCA2 sequenced and evaluated. And then really the sort of newest thing that most people are doing now when they do genetic testing is called multi-gene panels. And so then we could be looking at the Lynch genes, the BRCA genes, the RAD51C and D. We're looking at a lot of genes all at once. And this is useful because we have a growing understanding that many of these diseases, that ovarian and breast cancer, can result from many, many genes. So that's the first question. The next question I would ask someone is, when was your genetic testing completed? And why does that matter? And it matters because genetic testing has sort of changed drastically over the past 2 decades. So first, I would say sort of what comes as a surprise to many people is we've only sort of cloned and identified the BRCA1 and 2 genes and mutations in the past, since the mid-90s. And so often people will tell me that, they had their mother had ovarian cancer and passed away, but her genetics were negative. And if she passed away or was diagnosed before 1995, it's almost impossible that she had genetic testing. So, or if I see a woman who had ovarian cancer decades ago and never had genetic testing, it sort of prompts me to think about that and to offer testing to someone we may have missed because their cancer was diagnosed before we even had access to testing. The genetic testing for BRCA1 and 2 sort of had a dramatic change in 2006, where we were able to do sort of some more extensive sequencing, and that's called BART. And so if someone had their testing in the mid to late 90s or early 2000s, then I know that they didn't have BART analysis, and so that would be a reason for me to repeat the testing if their testing was negative. In 2010, there's something called next generation sequencing, and what is important about this is in the past we sort of had to do each gene or each test as a separate test, and so that made it very time consuming and expensive to look at lots of genes. But with next generation sequencing, you basically can do everything in parallel. So currently, if someone went to get testing, it doesn't matter whether they're testing just BRCA or they want to test 100 genes. The cost and the price is the same because of the way the technology works. Another really important sort of moment that happened was in 2013, there was a Supreme Court case that invalidated single gene patent rights. And this was important because prior to 2013, there was only a single company that was offering genetic testing, that was Myriad. And so I know that if a patient had testing before 2013, it is Myriad. And that's actually helpful sometimes because often a woman doesn't have her report. And so it's very easy then, we know exactly who to call to get the report and we can get the records. The problem is that testing was largely unaffordable for most women at that point. It was easily over $3,000. And that was the only place that was offering BRCA1 and 2 testing. And so we really had no other option. In 2013, when the Supreme Court sort of invalidated the single gene patent, multiple companies started offering genetic testing. And this was exciting because then the prices have dropped dramatically. And currently, if insurance doesn't cover testing, really the max out of pocket that someone should have to pay for genetic testing is $250. And so you can see a dramatic change from multiple thousands of dollars to under $300. So kind of in sum, if someone's thinking, should I have repeat testing? The answer is yes. Sometimes it is indicated, and that's based on changes in technology, which we can tell based on what testing someone had and when it was done, changes in family history. Someone may have had BRCA testing 10 years ago because of a history of ovarian cancer on their mom's side, but then found out that actually on their father's side, there's a lot of colon cancer or uterine cancer. And so perhaps that genetic testing should have included an evaluation for Lynch syndrome also and didn't. So that would be a reason to repeat testing. And then also based on changes in knowledge of genetic syndromes. So we're learning more and more about new genetic syndromes. And so, for example, on the list of genes, we now know that RAD51C and D contribute to ovarian cancer. And so if there's a lot of ovarian cancer in a family and all of the BRCA testing and Lynch testing has been negative, maybe we just weren't testing for the right gene. And maybe if we went back and repeated genetic testing, we would find a RAD51C or D mutation. And so I would say for this, genetic assessment by one's oncologist or primary care doctor or genetic counselor is absolutely critical, because we really have to closely look at the family history, the prior testing, and decide on an individual basis if repeat testing is necessary. And this is dynamic. You know, the answer might be no today, but perhaps 2 or 3 years from now, we'll have new information and it will be indicated. So in summary, inherited mutations account for about 20 to 25% of ovarian cancers. Information about a mutation has many health implications. So it has implications for cancer treatment, risk of other cancers, and risk of cancer among relatives. Genetic testing is complex and dynamic, and sometimes repeat testing is warranted. And for those with mutations, communication with family members is absolutely critical, and something that we as the medical team should really work towards facilitating. Thank you again for letting me speak with you tonight. I look forward to all of your comments and questions, and also want to just thank my team from Cornell, who has been so supportive of the work that I've gotten to do in cancer genetics.
Great, thank you so much, Dr. Frey.
So now let's start the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through all questions submitted, but we may not be able to due to time constraints. So the first question is, in what instances should my kids get genetics tested? And if they should be tested, at what age should they be tested? And what are the next steps if your child is shown to have a genetic mutation?
So that's a great question. Oh, sorry, was there more?
Yeah, what do you do with that information?
Sure, it's a great question, and it's something that I didn't touch upon, but you know, genetic testing is not something as easy as just saying, yes, I'll do it, or no, I won't do it, because there are a lot of really important consequences. So I talked about sort of what I would consider the positive consequences, which is knowledge about disease, treatment, cancer prevention, but there's some other really sort of more complex consequences. So number one is suddenly becoming aware that all of your relatives, including your children, are at risk for this and needing to talk to them about that. Also, you know, thinking about how is that going to affect insurance. You know, we know that health insurance, workplace insurance, there are acts and laws in place that protect people from genetic discrimination, but that's not the same for some of the luxury insurances like life insurance or disability insurance. So that's a real concern. And so, you know, the decision to do genetic testing really should also be preempted by a very thorough discussion about that. You know, I would say that for anyone who has a mutation, like a BRCA1 or 2 mutation, their first degree relatives, including children, should be made aware of it so they have the opportunity to get testing, and then they can decide on their own if that's something that feels right for them. Now, as far as age goes, in general, no one will offer this kind of testing before age 18, and that's because these cancers don't tend to, or really in general, do not present before that age. And so if you're not going to act on it, it's really believed that this is not something that should be done prior to age 18. And some would argue that even closer to the mid-20s is a better time, because we really don't start acting on it until age 25, when we start recommending MRI breast screening. And so I think it's, you know, what someone should do is discuss it with their children when they think their children are ready to think about it, because of course it is a lot of information. And then if someone has a child who's interested in getting tested, usually that involves seeing a provider, like someone like me, a gynecologic oncologist, or often a geneticist or genetic counselor. And then again, doing really thorough pre-test counseling, and then getting the testing. And then, you know, once someone has those results, if they're positive, which there's a 50-50 chance in general, then at that point, meeting with, you know, sort of the specialist who can help guide someone to the correct forms of cancer prevention and risk reduction. But it's a great, great question and an important one.
Thank you. So the next question says, I tested negative for BRCA1 and 2 and was diagnosed with ovarian cancer. Does this change treatment, and should I be tested for other genes?
So that's a great question. And, does it change treatment is probably a discussion for a whole other webinar. And we'll probably change multiple times while we're planning that webinar, because we have so much information coming out and so many exciting trials looking at PARP inhibitors. And I think this is really an area of debate right now in the field of ovarian cancer. How do we use PARP inhibitors best? But currently they are available to women who have both BRCA mutations and who don't have BRCA mutations. So I would say, it can help clarify treatment, but depending on someone's particular case and the discussion with their specific doctor, it may not change treatment. As far as whether or not to retest, I think it depends on that initial test. If the test was just looking at BRCA1 or 2, then someone does have the option to retest. The chance of finding something is low. It's probably, at most 5%, but that may be important information. And so certainly after kind of thinking about that and thinking about what the cost of that specific test will be, that might be something to pursue. Often genetic testing companies are not, or insurance is not paying for repeat testing, but sometimes it is. And so that's why it's also important to have that discussion sort of on a very one-on-one basis, but it's definitely something to think about and something to speak with a physician about.
So the next question is, will a vaginal ultrasound allow early detection of ovarian cancer if I have one each year? Is BRCA testing the best indicator?
So another great question. So the concept of ultrasounds is another complex topic, because I sort of said even in these slides, we don't think that they work, meaning we don't think that they're effective in catching early cancers or allowing us to catch cancer at a stage 1 or 2 versus a stage 3 or 4, but we still offer them. And I think that's sort of because everyone has, one patient or anecdotal experiences where it did work. And we think it's, it's not so invasive on the scale of sort of things that women go through that we do offer it. But I think we have to be very careful, because there's actually no strong data that it's effective. Many people are studying this, and maybe we just haven't found out the right mix of how often to do it or how to combine it with blood tests. And that would be great if we could learn more. But I would say the current state right now is it's not helpful. But I think most gynecologists and oncologists do offer it, and I do offer it to all my patients. But I think it's also important not to have a false reassurance. So if someone is 40 and was otherwise feeling ready to have a surgery to remove the tubes and ovaries, I wouldn't want them to say, well, the ultrasound was normal, so I can delay it for a year, because then I think it's actually more dangerous than it is helpful. And I would say, I think the ultrasound really is not so helpful. BRCA testing, if someone has a mutation, that is helpful knowledge, because right now, then we would strongly recommend that someone remove the tubes and ovaries when they're done having children.
The next question is, for a person who has Lynch syndrome and a history of ovarian and uterine cancer, as well as a family history of the cancers that are associated with Lynch syndrome, is maintenance therapy available?
So I think that would probably depend on the very specific situation. So for ovarian cancer, their maintenance therapy is now available for almost all patients, and it's something I think we've really embraced as a community. And so I think certainly, especially with PARP inhibitors, there is an option. Even in Lynch syndrome, we are using PARP inhibitors for some people with ovarian cancer. There's also an option for immunotherapy if it's a cancer that we know is Lynch driven. So if it's caused by Lynch syndrome, we can use immunotherapy. That hasn't been used yet as a maintenance therapy. And for those of you who don't know what maintenance is, that means that when someone completes their treatment and they have no disease, we're giving them a treatment to kind of keep them that way, to keep the disease sort of gone. And so we aren't using immunotherapy yet for that, but we are using immunotherapy for recurrent or metastatic cancers in women with Lynch syndrome.
Thank you. So the next question is, what screening should one have with Lynch syndrome receive, and how often should that person be screened?
Sure. So I left the slides a little more vague for Lynch syndrome, and the reason is, the guidelines are constantly being updated, and I think now we're really moving towards gene-specific recommendations. So I gave you a list of kind of 5 genes: MLH1, MSH6, PMS2. There are 5 of those genes, and it really depends actually on someone's specific gene and on their family history, and that's going to tell them in general what to do. But I could say, sort of for almost anyone with Lynch syndrome, we do recommend a colonoscopy every 1 to 2 years, usually beginning at age 21 to 25. And then starting at age 30, we're offering endometrial biopsies and pelvic ultrasounds. An exciting thing that we have at Cornell, which I actually participated in one today, is we're trying to do the endometrial biopsy at the same time as the colonoscopy, because we know we're asking women to do sort of 2 difficult procedures, and doing a biopsy in the office can be really painful. And so if a woman has to get a colonoscopy also, why not do this at the same time? Well, she already has anesthesia. So we are aware of the cost of all of these interventions, and that it's not nothing. But I would say there are other things that we sometimes do for Lynch syndrome. Sometimes we check the kidneys, sometimes we do imaging like CAT scans or MRIs, or look at the pancreas, or check urine, and that really depends on someone's specific mutation and their specific family history.
Thank you. So the next question, this person says that they're BRCA or BRCA2 positive, and they want to know, should they see an optometrist or ophthalmologist?
It's a great question. And so there is this concern that, especially in BRCA2, there may be a risk for melanoma in the eye. And I can tell you the risk is extremely low. And if you sort of even ask most ophthalmologists, they will tell you, like, find me the papers, because our literature is so scarce. But I would also say that, probably for most people, seeing an ophthalmologist every year or every couple years is recommended anyway, just for an eye exam. And so I would at least do a baseline check with an ophthalmologist, and then make a plan with that ophthalmologist, how often that ophthalmologist thinks that the person needs to be followed. But on the scheme of all the things we recommend, that's sort of the lowest on my list. And so I mention it, but I would say, the other everything else we recommend is much more important. So that can sort of be at the bottom of the list.
All right, so this person is asking whether there have been many advances in genetic testing since 2018.
Since 2018, so over the last 2 to 3 years,
yeah.
I would say no. One of the things that, if someone wanted to know is you can kind of, just get a copy of the test. And then you can look to see what genes were included on the test. And then, you could look at slides like mine tonight. I tried to include sort of in my list all of the genes that we know are associated with cancers. And so you can kind of compare the testing you had to that. But, that's also something you could just ask your treating physician about, or, if you've seen a genetic counselor, they'll often, happy to do check-ins with you, where you just, call once a year, see them once a year. Because again, we used to think is like someone has to see genetics, it's a one-time thing and they're done. And now we really think of it has to be a dynamic relationship where we're constantly checking in. So, I can't think of anything dramatic that's happened in the last 2 to 3 years, but, again, it would depend on the specifics of what testing someone had in 2018.
Okay, thank you. And so this person is asking about peritoneal cancer, and their mom had a complete hysterectomy. Oh, what can you tell us about peritoneal cancer? My mom had a complete hysterectomy, and then 9 years later was diagnosed with peritoneal cancer.
Yes, this is, I guess, sort of one of the worst parts about this disease. And what peritoneal cancer is it's a cancer that looks and acts just like ovarian cancer, but it seems to not start in the ovary or the tube, but actually starts in the peritoneum, which is sort of just the lining of your abdomen. And I sort of describe it to a patient as sort of, it's like the skin on the inside. So it's not an organ that you can remove surgically, it's just there. And unfortunately, rarely, especially in women with BRCA1, that can turn into a cancer. And so While we know that taking out tubes and ovaries can really significantly reduce the risk of ovarian cancer, that risk never goes to zero because there's always this chance of a primary peritoneal cancer. And, we don't really know what to do as far as, how can we catch that early or prevent it? I think, again, that's an area that's still kind of needs to be further evaluated. Some physicians will still recommend doing a blood test like a CA-125. I think most oncologists, including myself, would say that even after a woman has had patients every 6 to 12 months, and whether or not me seeing them, does anything, I can't say, but I just think that women and people still need to be aware that these risks exist. I mean, it's similar for that. It's once someone has a mastectomy, it's not impossible to get a breast cancer because we know that there can be still some lone breast cells or breast tissue left. So, unfortunately, we have to remain very, very vigilant about sort of these cancers, and if anyone has a symptom, that has to be evaluated.
Mm-hmm. Okay. And so this person's asking, once we know from genetic testing that a person is at a higher risk for certain cancers, why is blood testing not done for those tumor markers to detect early?
So we can, and many people do what's called a CA-125, and that's a blood test. But there are a couple issues. The first issue is that we know it doesn't work. So we know that in about half of early ovarian cancers, the CA-125 will be normal. And we also know that there have been huge studies where we tested CA-125, and unfortunately, even if we test it frequently, we don't pick up ovarian cancers early. And I don't think anyone really knows why that's the case, but I think, probably part of the problem is that the CA-125 doesn't go up until the cancer is really extensive. And so unfortunately, it doesn't really give us any benefit as far as catching things early. The other issue is CA-125 can be high, and that's the CA-125 I'm referring to is the blood test I think that you're referring to. It can be high for many other reasons. Some women, just with their normal period over the course of a month, have rising and falling CA-125, and so that can be very scary to have a CA-125 that's elevated only to come back the following week and have it be normal. Women who have other conditions like endometriosis or gallbladder issues or pancreas issues, they all can have high, very high, often CA-125, and it's not an indicator of ovarian cancer. So I think the combination of this being not a perfect test and also, not an effective test are why we can't rely on it, but we do offer it to women who have BRCA mutations.
Mm-hmm. Okay, so this question is asking, in the absence of genetic testing, how should children of BRCA positive ovarian cancer mother be monitored? Monitor as if positive.
So another good question. The question is, so I guess if a child doesn't want to get tested, what are the options? And so I think breast screening is a little easier because I think you can, consider doing breast MRI and mammograms as far as screening. But I think the decision to surgically remove tubes and ovaries would be, it would be very hard for, I think, any physician to think that's an acceptable risk for someone because, there's only a 50-50 chance of having a mutation. And so we know that taking out tubes and ovaries doesn't come without its own risks. Putting someone into menopause 10 to 15 years before they would naturally go through it certainly has long-term risks for heart health and bone health and maybe for, memory health and many other things that we're learning about. And so I don't think that you could get a risk-reducing surgery, but there are things that someone could do. Someone may choose if they're deciding between different methods of contraception. Someone may have thought maybe I'll do an IUD and thinks, well, maybe I'll do birth control pills because I know that would reduce my risk of ovarian cancer. So I think it's a tough question, and I think ideally to have the more information is better. But I understand also that some people that's not the right decision for them.
And I do have a sort of a follow-up question to that. Do you have any recommendations or resources to help people have those potentially hard conversations with family when it comes to genetic testing and why they should get it and what that means? Or do you have any recommendations for that?
It's a great question, and that's sort of what a lot of the research that we're doing here is aimed at. And so, what we're doing, and we have a study we're about to launch, is we're going to basically offer to call the relatives, and that can be that, and we're thrilled that can be with our patients, and we're thrilled if relatives want to come to the physician visit with their relative. And so, that could be part of a study like ours, or that could be in general. You could bring your relatives with you to your genetic counselor, geneticist, or oncologist, and have the conversation together. Another thing that we're offering to call. We also have created an educational video. Now that's not perfect because it's hard to make one video that applies to everyone, but we're hoping that this video kind of makes it a little bit easier. But I agree, this is an area that we are not great at, and I'm certainly open to ideas and love getting feedback from my patients about what's hard about this and how we can make it easier, because I think this is a way that we're really failing our patients by putting the burden on them to sort of communicate this very complex and emotional information.
That study sounds really interesting, though, about, and that's great. I'm sure that'll help a lot. So this person has had ovarian and endometrial cancers. Their father died of colon cancer, and they're asking whether genetic testing is something that they should still do, though they've already been treated for both those cancers. They said that Lynch syndrome was only assumed because I had them, but it was never confirmed.
Yeah, so one thing I would stress is that essentially every medical society at this point recommends that all women with epithelial ovarian cancer, which is the most common type of ovarian cancer, should have genetic testing. And that's whether the cancer is now or the cancer was 50 years ago, that all women should have genetic testing. And we recently kind of reviewed all the literature on this. And even though there's been this recommendation for over 5 years, this recommendation has been out. Probably less than 50% of women in the community actually get genetic testing with an ovarian cancer diagnosis, which is startling and upsetting. So I would say anyone with ovarian cancer should and could, in general, insurance will pay for this, because this is sort of the guidelines now, should have genetic testing. Especially someone with that family history that, maybe more of a Lynch syndrome, I would say absolutely, because I think that information may inform risk for other cancers. It also may inform risk for relatives. And so I think absolutely getting genetic testing sounds warranted. And we don't like to make we don't make the diagnosis just based on family history. Now I'll say the only other thing I should say about that is if someone has a really strong family history and their genetic testing is negative or normal, that doesn't mean that we don't have to worry, because I think we have to appreciate that we don't understand everything about genetics, and there certainly could be things that run in families that we can't test for yet. And so, I think that genetic testing can be informative and important, but it doesn't wipe away a very strong family history, and that still might make someone at higher risk.
Mm-hmm. So this person's asking whether for pancreas checking, to get their pancreas checked for a BRCA patient, should they see a GI doctor for that?
So I think that the audience is really hitting on the most complex points tonight. The whole idea of pancreatic screening is new, and we don't have a lot of information about it. And there are no sort of big algorithms that we can rely on to tell you exactly what to do. I'll tell you that our protocol at Cornell is we have a team of gastroenterologists who are also trained in genetics. And so they're very aware of these syndromes that increase the risk of pancreatic cancer. In general, they're offering screening to women who have a mutation like Lynch and BRCA and have a family history of pancreatic cancer. And those patients, they would sort of say, yes, we can do screening. And for someone who has a BRCA2 mutation and doesn't have a family history, that's where it's a little more vague. Here in general, if someone wants to have that screening, we do offer it. And that's, again, done through our gastroenterologists. But it's hard to say who should be getting it because I think no one has those answers yet, but I think it's something to think about. And I think that over the next couple of years, we're going to learn a lot more. But certainly someone who has BRCA2 and a family history of pancreatic cancer would be a good candidate for screening.
Mm-hmm. So this person is asking whether there is the there are the same recommendations for uterine cancer to get uterine cancer patients to get genetic testing as there are for ovarian cancer.
I had one slide that showed the number of cancers in the US per year. And you can see that there are many more uterine cancers than there are ovarian cancers. And we know that only about 3% or so of uterine cancers are driven by genetics. And so there is not a guideline that all women with uterine cancer should have genetic testing. But most centers would say that anyone less than 50 should have genetic testing if they have uterine cancer. Anyone who has a strong family history of cancer and has uterine cancer should have genetic testing. And then also, everyone who has uterine cancer should have their tumor assessed. So there's actually a way to look at a tumor, and this should be done by the pathology department, and it should be routine practice, where you can actually look for changes in the actual cancer. And sometimes those changes can tell us this is someone who we need to triage for genetic testing because this specific cancer is more likely to be genetic. And so I think that's sort of how we take the 65,000 cases a year and decide which ones need genetic testing, often through looking at the tumor.
Mm-hmm. So this sort of goes back to, families and genetic testing, but this person is asking what genetic testing do male children need to have?
So this is a really, really important question. The risk of a male inheriting the mutation is the same as the risk of a female. So it's 50-50 if one of the parents has it. For syndromes like Lynch and BRCA2 especially, these men unfortunately can get cancers. And so there's absolutely an indication for testing because it will give men the opportunity to have screening for colon cancer or prostate or pancreatic cancer. And some people ask, what about BRCA1? We don't know that there's a higher risk really for cancers in men, maybe pancreas, but we're not sure. And is there a role? And I think that's a personal decision. But also one thing to think about is that man may then go on to have children. And so it may be important for that person's children to know. Something else that should come up in counseling is the option for using assisted reproductive technology to sort of create embryos that don't have a mutation. Now, I think as a physician, we should never encourage a woman to do this or not do this. And what I mean is that a woman, if she chose and had access to seeing a fertility doctor, could create an embryo that does not have a mutation, and then use that to get pregnant to sort of try to ensure that the pregnancy doesn't have the same mutation. Again, that's a very personal decision, whether that's something that someone should do or not. But I think as a physician, we are bound to at least tell patients that that's an option. Women should know that's an option. And so, if a man knew he had a BRCA mutation, maybe that would affect the way that he decides to have children. And so I think it is important.
And then in terms of genetic testing, I also wanted to sort of get your thoughts on, going the traditional route of getting tested, seeing a genetic counselor versus, these by the mail genetic tests you can do like 23andMe or the website Color, and sort of your thoughts on using those versus, going to see a genetic counselor and getting it done that way.
I would say I have conflicting thoughts about this. So on the one hand, I think there's a problem with especially 23andMe in that from what I'm aware, it only tests for the 3 Ashkenazi Jewish founder BRCA mutations. And so sometimes I'll see a woman who says, I know my BRCA is negative, and I'll say, how? And she'll say, I did 23andMe, and I'll say, well, are you Ashkenazi Jewish? And she'll say no. And so I would say for her, there was almost a 0% chance that we were going to find it with that test. And so I get a little worried that people think they've had testing, or they may think that they had testing for Lynch syndrome and didn't. On the converse, some people do 23andMe not even realizing that BRCA is on that panel, and then suddenly get this information that is shocking. And maybe that's someone who was about to take out a life insurance policy and now can, or maybe that's someone who didn't want that information and now you can't take that back. And so I get a little worried about 23andMe. On the converse side, I would tell you that there are probably about 4 million Americans who have a mutation like Lynch or BRCA, and we know that at least 80% and probably higher don't know it. And so what that means is the majority of people with these syndromes are walking around and have no idea. And the sort of number of genetic counselors cannot grow at a fast enough pace for all of these people to be seen by a genetic counselor. And it's just not possible. So we have to think of alternative care delivery models. Another study we have going on at Cornell that we're about to launch is, can we use artificial intelligence as far as sort of risk stratifying people? And so, maybe it's doing a video, maybe it's doing group counseling, maybe there's actually ways that you can text back and forth essentially with, they're called bots or chat bots, and they can actually tell you, based on your family history, you are at risk or you're not at risk. And a lot of the counseling actually can be done through artificial intelligence or through telephone. So I think we have to think of better ways so that everyone who needs and wants testing can get it, because it's not possible to sort of scale testing the amount that we have to and rely on face-to-face in-person genetic counselor visits. But I also think it can be dangerous to, have someone not really realizing what they're getting into and just ordering something online.
Great, thank you. And so I think that's all the time we have. So this is probably a good place to end, but thank you so much, Dr. Frey, for all the information you presented and answering all those questions. We really appreciate it. And thank you to all of you for participating tonight and submitting your great questions. I do want to mention that there will be a survey after this, so please take a moment to fill that out. The survey is going to show up in your browser when the webinar ends, and then there will also be a link to the survey that will be emailed out to you afterwards. So we really love to get your feedback so we can continue to improve our program. So thank you again, Dr. Frey, and everyone who joined us tonight.
Thank you.